Good evening, everyone, and welcome. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Network and sit in the education team on the beautiful Central Coast. Welcome tonight. I'd like to acknowledge the local custodians of the land of which we meet this evening and honour elders past, present and emerging. Just a bit of housekeeping. As usual, we have our poll at the end. I strongly encourage you to please complete that. It only takes a couple of minutes and we base our future events on data and feedback from that. So it's really important. And I strongly encourage you to please complete that. And we do appreciate your input and your comments. They're all noted and fed back to presenters and to the team as well. Also, questions, if you pop those into the questions box, Dr. George Page will be monitoring the questions box tonight and asking those questions for you. So this is your opportunity to ask those questions. So please take advantage of that, and we'd love to be as interactive as possible. Also, we are being recorded, and a copy of this with the presentation will be available in our education library through our website in the coming days. It gives me great pleasure now to hand over to Dr. Georgia Page. Thank you so much for being with us once again, Georgia, and always supportive of our education on the coast and across the region. And Georgia's going to introduce Dr. Ann Purcell. So thank you, Georgia.
Yeah, great. Thanks, Mel. So welcome everyone to this education session on Wound Care 101, which is part of the vertical integration pilot for Central Coast medical students, JMOs, GPs and GP registrars. So I'm a GP in Erina, I'm on the Central Coast, and also GP lead for the vertical integration pilot. So wound care is a topic that has been requested by participants attending our vertical integration sessions, and it's often poorly taught in our medical training, ranging from medical school to hospital and GP training. So when patients attend our practice, often we look at a wound or non-healing ulcer and we stare at the wound, we wonder how we're going to treat this, look at the cupboard of dressings and ponder what's the best way to treat the patient. But it's not just about what dressing to use. There is so much more to take into consideration. And we're very lucky to have the expert knowledge of Dr. Ann Purcell to talk us through the assessment and management of wounds. So I'd like to welcome and hand over to Dr. Ann Purcell, who is a nurse practitioner in wound management at the Central Coast Specialist Wound Centre. So thanks, Anne, for joining us.
Hello, everybody, and thank you for the opportunity to be able to speak to you today. There's a slight technical hitch. I'm just opening my presentation again. For some reason, it just shut down, but thank you for being here. Management across this country is quite massive considering our population base. We have approximately 450,000 chronic wounds in the country at one time, and there's an awful lot to do to try and heal them because they're not easy, they're very complex. So I'm just going to go into the presentation again. Sorry for this delay. It's coming up shortly. We tried to fix this. There you go. Hope you can see it. And here we go.
All good. Yes.
So, thank you. Now the first, there we go. Oh, there we go. Okay, what a lovely wound to open up with tonight. Well, why am I showing you this? This is because we cannot heal this wound looking like this, obviously. Now, this wound was treated for 6 weeks with oral antibiotics. Even so, antibiotics will not fix this. What is required is removal of all that non-viable tissue. So when this was presented to me, I know I love to debride and remove non-viable tissue. The pain was the issue. So therefore I spoke to my trusty surgeon. Within a day, this person was in theatres. I went with them and the surgeon lifted the cap off, used his hands, all the old hematoma that was caused from falling in the garden fell out of this wound, and it was quite clean underneath. Right at the bottom of the wound was a small 50-cent piece area of healthy granulation desperately trying to heal. Now, so apart from, see, this woman had very little history apart from obesity and high blood pressure, but there's no capacity for her to heal unless this wound was cleaned out and then the right management put in place. So this is the result of the removal of the non-viable tissue, and of course had negative pressure wound therapy, and of course this picture B, we had a lovely healing wound. Now, here's a much smaller wound, about 2 by 2 centimetres. It's a chronic little chronic ulcer. It doesn't seem like very much, but it was there for a long time. The same of what I've just spoken about applies to this small wound. As you can see, the inflamed wound bed, the wound edges. You can see the slough slime on the wound bed. The skin is dry and fragile. Healing this wound will not happen unless we put the right management in place, looking at the edge, the skin, the non-viable tissue and the wound bed, all those. So it's really important. It doesn't matter what the wound is, where it is, how big it is, the same principles apply. Now, it's important in your practices, if you can actually download from your Wounds Australia, the standards for wound prevention and management. This is the 2016 version. And there is a new one being revamped at the moment. So very important to have this in your practice. It's not a big document, it's an easy read. So may I recommend that that's actually downloaded and placed into your practices. And obviously the standards are to be followed. And I'm sure you all understand all about standards. Now, let's get on to wounds again. Everything, literally everything affects wound healing. There's nothing that doesn't. Pain, even at a cellular level, affects wound healing. There's nothing that doesn't, so be suspicious of everything. A lot of our patients have massive load of comorbidities and on so many drugs, etc. So consider everything when your wound of your patient's wound is not healing. So just to give you an example, as you can see on the right-hand lower corner, there's the phases of wound healing, which you're all probably quite aware of. Unless we follow those phases exactly how they should be, we will not heal. So, for example, medications on their own, and so many of our patients, particularly our elderly, are on lots of drugs. Simply, corticosteroids literally affects every phase of wound healing. Having said that, I'll show you later on how we can use corticosteroids to actually benefit wound healing as well. It's a bit catch-22. Vasoconstrictors, tissue hypoxia. Anti-idioplastic drugs are going to affect the collagen synthesis. Dilantin suppresses wound contraction. The non-steroidals and anticoagulants affect coagulation, and that's usually the first stage of wound healing. And of course, drugs such as hydroxyurea, which is not used often, it actually causes leg ulcers and are usually used by a hematologist, and it requires often some negotiation with the hematologist to try and reduce or stop the hydroxyurea for a little while, because the ulcers can be quite unpleasant. Antiseptics, we'll talk more about those later on. But they can actually directly affect wound healing if they're not used properly. That, for example, they can actually prevent the development of. They can destroy the cells actually when they're applied if they're not used correctly. But we'll talk more about that later on. When we're doing any wound management, of course, we must look at diagnosis, because how we treat each wound is different. The principles of wound care are the same. But for example, picture A is a venous leg ulcer covered in Pseudomonas, as you can see the green iridescent colouring. B is an arterial ulcer. You can tell by how the wound looks. And if we treat a venous leg ulcer exactly the same as an arterial leg ulcer, we can have all sorts of problems. In fact, be quite harmful to those, particularly the person with arterial disease. So we have to be very sure of our diagnosis. Picture C is after a breast mastectomy, after radiotherapy. Very difficult wound to heal when there's been any radiation or any scarring. Of course, picture D, some wounds do not heal. However, we still apply the same rules for wound management. For example, for this lady, we would control the odour, the bacterial load, and the pain. E, as you can imagine, that's a diabetic foot. Trauma, infection, depth is going to be a problem. Offloading is going to be important. So how we treat that particular wound, very different to how we're going to treat that venous leg ulcer. And of course, lo and behold, occasionally I see acute wounds, not very often. And here you have a finger caused by just a bit of trauma. It's quite a healthy wound bed, granulating, healed beautifully, not a problem with just the right dressing on it. You don't see a lot of those wounds, unfortunately, in my practice. I see the nasty long-term chronic things. So just to give you an idea on what to do if you're all of a sudden presented with these wounds is you've probably heard of the time principle down below here. Now it's only very recently it's been called times. The S has been actually added on only in the last year or so. Of course, when you are looking at a wound, wondering what on earth to do with it, think tissue. Is it non-viable? Is it deficient? With the I, think of infection, inflammation, and biofilm. Now, I will be talking on a few slides on biofilm. It's a very crucial component of wound care. Moisture balance, also vital. Wondering what to do with your wound? Think moisture balance. The edge of the wound and the surrounding skin are both as important as the wound bed itself. And of course, this triangle of wound assessment is fairly new, and you can see the document to the right. If you go onto Wounds International site, all these resources that I'm showing you today are easily downloadable, and all the experts have put this information together, very easy read, a quick read, and it actually covers everything. It's all very evidence-based. Now, before we get on to actually what we're going to put on the wound, we have to, as we said, we talked about diagnosis. Now, the location of the wound can tell us a lot about diagnosis. Of course, the gaiter area is often venous. The sacrum, heel, trochanter, etc., pressure. Dorsum is often arterial and vasculitic ulcers. The shin can sometimes be necrobiosis lipidoica, which is, and if you haven't heard of that one, that's usually people, not always, with people, men in their 40s, diabetes, and they often get wounds down their shins. The lateral malleolus, for example, it could even be venous, arterial pressure, or hydria. So, hey, it's a difficult diagnosis. The plantar lateral aspect of the foot, you've got diabetic ulcers. And of course, and I'm sure you've seen many patients with sun-exposed areas and skin malignancies. So this can tell us what sort of wound it is by just the location. Now, exudate. As I said before, wondering what on earth to do with your wound, think exudate. If you're stuck for what to do, it has to be controlled. So, is it caused by infection or inflammation? For example, this picture down here, I don't know if you can see my cursor, the one on the bottom left. This is caused purely by poor exudate control, and as you can see, the massive inflammation, very nasty. Is it caused by dependency? Quite often people do not elevate their legs, or they might be sitting at the desk or their kitchen table for hours on end. Often, as you would see in your practices, cardiac, renal, liver issues are a big issue with lower leg edema particularly. And controlling that with something like compression is very difficult because of the fluid shift back into which causing cardiac and renal issues. The thing is to identify the load. We're going to talk more about exudate, but you don't want a dry wound, you don't want a wet wound, you just want a moist wound. So you really do need to know your dressings and their capacity to control exudate. Putting a combined dressing, for example, on any of these wounds, particularly the one on the left, or any of those highly exudating wounds, it will not cut it at all. We have to have very absorbent pads that take the fluid away from the skin, much the same as a nappy would do on a small child. So we have to look also when we have lower leg edema or even upper lip edema, compression therapy, and whether the patient can have it safely. Has the vascular studies been done? Is the wound painful? So there's exudate is a good way to determine, oh, what do I do with this wound? Think exudate. It's often a way to get around a lot of decision making. We also must consider the wound edge. When we talk about diagnosis, you can just look at a wound and you think, yep, I know what the diagnosis is. Of course, venous leg ulcer, you have a sloping edge. When you have a vasculitic or arterial wound, often it's punched out and devitalized, little granulation, low exudate. A rolled edge is a BCC. You've got the everted edge is the SCC. The undermining can be infection or biofilm, increased microbe load, tuberculosis or syphilis, for example. And of course, if you've got a purple edge, you know, and we'll talk more about this in a moment, you might have a vasculitic component to your wound, such as pyoderma gangrenosum. So very nasty. And of course, this here, and we'll talk more about this as well, this is hyperkeratosis on this second picture down from the right. That is obviously has to be removed, which can be caused by pressure and sometimes a biofilm. And a biofilm, much more discussion coming on that. Of course, diagnosis, again, look beyond the wound. Look at that, the picture on the right. Look at the skin, that's classic venous eczema or venous dermatitis. And you can see the ankle flare, you can see there's a bit of edema, and you've got this dermatitis. So this person has venous disease. Look at the surrounding skin of that lower leg, the hemosiridin staining of the picture on the left. That's classic venous disease. So look beyond the wound for a diagnosis. The foot on the bottom picture, you've got pale skin, it's hairless, it's fragile, you've got a small wound that's likely to be very painful, it's a bit punched out. This, to me, just looking at that picture, shows it's likely to be an arterial component. So, of course, investigations are required. The limb tells us an awful lot. And of course, I'm talking about the lower leg a lot because that's the bulk of my work. I see a tremendous amount of the bulk is really below the knee, or below the, mainly below the knee. That's most of my wounds I see because they're the hardest to heal. The limb. Okay, look at that left picture there. That is classic venous disease. You've got the upside down champagne bottle leg. The reason for that is because you've got the lipodermatosclerosis at the ankle. You've got increased hydrostatic pressure, so you don't get expansion. The skin changes. It's very fibrin. So thus you get this shaped leg. You've got the hemosiridin staining, and you've got the edema, of course, classic venous disease. However, if you look at these nails on the bottom of that same person, they're very crusty and horrible. Is that fungal? Is it peripheral vascular disease as well? We don't know. The lady on the right, pale, not much edema, punched out leg ulcers, crusty toenails, hairless, likely to have a lot of pain in that wound, arterial disease. I know that patient definitely was. And of course, look at these feet at the bottom. They're highly deformed feet. You can see the areas of pressure. You can see that there's amputations already. You can see the pronounced metatarsal heads. You can see that this is a diabetic foot, all sorts of problems. Podiatrist has to be the best friend of this patient. Offloading, the potential for disaster than what's already happened with an amputated feet is paramount. And a wound, with those wounds you can see there, they're dry, so we have to find a product that's going to, after removing the non-viable tissue, of which I'll talk about again later, we have to provide a product that's going to hydrate those wounds and hopefully heal and take the pressure off. So, one of my pet subjects is wound-related pain. Most wounds are painful. The most painful wounds are usually the arterial wounds, but all wounds can be painful. Of course, people with diabetes don't seem to have much pain due to neuropathy, but the worldwide evidence will tell us that pain is the worst during dressing change. So please be very mindful. So this will influence what you can do for your wound, what the products you use, if you need compression, whether you can use it, obviously the pain strategies to use to try and reduce pain systemically. This is a very big deal, and a lot of our patients can't tolerate the most ideal evidence-based practice because of their pain. So this really needs to be right at the top of your list when you've got a patient with a wound. Unfortunately, it's only 2 slides today on wound-related pain, but of course it's a much bigger subject, of course, I'm sure you're aware. May I just stress the different pain types and getting your patients to highlight and describe what their pain feels like. To ask them, give me some adjectives, to ask them to get, and so what you have, nociceptive pain, you can see the descriptors there, and the many descriptors of neuropathic pain. And of course, patients can have both mixed pain with nociceptive and neuropathic, and it's quite distressing. It's not new to you, I'm sure. It's devastating, and of course neuropathic pain is very difficult to manage, and often these people, and after a while, within about a few hours, you can actually get neural changes. You get neuropathic pain very quickly. Chronic pain is horrendous and very difficult to treat. So be very mindful before applying any product to a wound. Think pain first. In relation to what sort of products are going to either cause pain or help pain. So it's a big deal. So I'll leave that pain, wound-related pain there now, but it's a very, very big subject on its own. Now, let's talk about another pet subject of mine, which is non-viable tissue. As you can see, all the wounds on the right are covered in different types of non-viable tissue. It's what I do mostly in my practice is deal with non-viable tissue, apart from the obvious other stuff like assessment and things. So you've got non-viable tissue will hinder adequate wound assessment because you really can't tell what you're looking at because you can't see beyond it very well. It will stop granulation and definitely prevent cells from migrating from the wound edges. There's no chance that these wounds will heal without removal of the non-viable tissue. It will encourage bacterial growth. Obviously, then you get infection. It will possibly cause malodor. It will increase the metabolic demand, and of course, it will promote protein loss. It is a must that non-viable tissue is removed somehow. Now, biofilms, the scourge of the wound world. So let me explain it quite simply for you. Really, I don't know if you've ever heard of biofilm. It's only been really talked about in our practice in wounds for the last, I'd say, 5-10 years perhaps. We know more about it now because we have molecular diagnostics. We didn't know anything about, but we did know something about biofilm. Dentistry did some work in the early days, but really the real knowledge of biofilm is over in the last 10 years, I would say. What happens is you have planktonic bacteria that will adhere to the wound bed. It can be one species of bacteria or microbe. It doesn't have to be bacteria. It can be up to, it could be 500 species. Then they attach, they permanently attach, and then they quorum sense, so they actually talk to each other chemically. They mature and grow, and then they spit out more planktonic bacteria and then embed themselves, and the whole process starts again. They've covered themselves in a exopolymer slime, which actually prevents the effect of antimicrobial dressings and antibiotics. It is microbes at their survival best. They are absolutely amazing. We loathe them, but we have to respect them. It's extraordinary what they can do. Now, biofilms, to explain a little bit better, planktonic bacteria and biofilms are as different as caterpillars and butterflies. I love this quote. The same genotype, a totally different phenotype. And phenotype, but what we mean by phenotype is the behavior. So let me explain that a bit further. Now, looking at this slide, the picture on the left, this explains the whole biofilm thing very well. You've got that yellow area, that's the biofilm itself. The green little dots, they are planktonic bacteria within the biofilm and on the outside of the biofilm. The little pink dots you see, they're actually persister cells, little dormant cells that decide to survive and that survive and prevent infections from being killed. So what happens is you give an antibiotic, and you've all seen it, the waxing and waning of infection. It doesn't just have to be wounds. You look at bladder infections, for example. You give antibiotics. The antibiotics kill the planktonic bacteria in the biofilm and on the outside of the biofilm, but they do not kill the persister cells that just sit there, and all of a sudden you have the infection starting all over again. And you can have up to 10% of the cells within a biofilm are persister cells. So it's extraordinary how these bugs have developed to protect themselves from antimicrobials and antibiotics. Amazing. This is a bit of a scary slide. Biofilm formation. So we talked about that reversible attachment right at the beginning of their development. Is that when we have to capture, we have to get in there and try and stop the progress. This can happen, and they're usually planktonic bacteria, in minutes. Then stage 2, you get that permanent attachment, you get some gene expression, you get more attached, and then you get the quorum sensing, which is that communication that's done chemically with all the species doing it together. And that can take only 2 to 4 hours. Extraordinary. Stage 3, you get the slime developing, the matrix, the biofilm, and this can happen in only 6 to 12 hours. And then you get increased tolerance to biocides at stage 4, and you get a mature biofilm before it spits out and starts all over again in only 2 to 4 days. We'll talk about how to deal with biofilm during this presentation, but if we do debride them, which is the most important part of removing a biofilm is actually using debridement. If it's not managed well after debridement, the wound is not managed well after debridement, then you'll have a biofilm developing within 24 to 72 hours again. It's extraordinary. So this is our battle. It's a very, very big battle we have in wound care. And the next slide will show some lovely pictures of biofilm. And you can see these are really nasty wounds. And if we can't technically see a biofilm because they're obviously microscopic, but we can guess they're pretty much there. You can tell these are slimy, they're full of microbes, it's horrendous. The one species that tells us that it's in the biofilm state is Pseudomonas, and you can see that foot on the right lower side. That is classic Pseudomonas infection, and that is Pseudomonas in its perfect biofilm state. At least it tells us it's there and we can manage it. A very opportunistic bug that is sometimes very difficult to get rid of. So other potential biofilm indicators are, you worry if you've got an infection about an implant or medical device, an infection lasting more than 30 days. You've got that, we talked about that, infections that wax and wane. With chronic infection, as I said, it's not just about wounds, it can be anywhere. Secondary sign of infections like slow progress and increase in exudate and pain. Incomplete response to antibiotics, and of course the infection site builds up with slough and other non-vital tissue. This picture on the left is a new prosthetic joint has been placed into this knee. Obviously there's an infection. As soon as you see that is an orthopedic disaster. Even if this person had infection lower down the leg, alarm bells have to go off. Get your infectious diseases, people, because if you get a biofilm on your prosthetic joint, it is a disaster. Do they have weeks upon weeks of antibiotics? Do they have it removed, antibiotic spaces? It's just a disaster. So we really worry when we've got internal hardware and the biofilms, again, infection causes guaranteed will be biofilm all over that prosthetic joint. It's terrible. More clinical indicators, I've already mentioned slough, maceration, tunneling and undermining. The edge of the rim is undermined or there's pain and swelling. Hyperkeratosis, as I said, is not always due to pressure. It can be also due to biofilm. Of course, there has been evidence of people in a critical care environment who have not been walking, who have developed hyperkeratosis on their feet. So be mindful, it could possibly due to biofilm. Just some indicators. They're everywhere, biofilms. Now, understanding biofilms in wounds, the key statements. Biofilms are present, if not in most, if not all chronic wounds. This is not good because we see a lot of chronic wounds. The presence and response to biofilms delays wound healing. Biofilms in chronic wounds are more likely to be established and more established and mature. They promote the presence of anaerobic bacteria. Biofilm may consist of a single or multiple bacterial species. Dr. Matthew Malone from Liverpool Hospital has done some excellent work on biofilm, particularly he's a podiatrist, and he has discovered up to 250 different species in an infected diabetic foot wound. Now, of course, the average would be about 35 species, but he has found up to 250 on one particular wound. So you can see it's quite a difficult problem. Biofilms may progress to contain fewer, more dominant species over time. Biofilms are more tolerant to host immune response, and their microbial diversity are not influenced by the wound type. So you can see biofilms is a massive subject at the moment. So a little bit, last slide on biofilms. As you can see, it's a bit of a pet subject, but it's such a crucial component of your wound management. If you have a burn that's chronic, consider it biofilm. Anti-biofilm strategy should continue till the wound displays healthy granulation tissue or is on the healing trajectory. Now, debridement, whether it's surgical, whether it's conservative sharp debridement, whether it's autolytic debridement, is absolutely paramount in treating these wounds, these chronic wounds particularly. You must get rid of the biofilm and keep it away as much as we can. Systemic antibiotics cannot eradicate a biofilm. So just think antibiotic stewardship. Choose a topical antiseptic that have known biofilm properties, and I'll be talking about those later. Consider biofilm treatment strategies when a risk of a surgical site infection or a dehiscence, because acute wounds can have biofilm. Up to about 60% of our acute wounds have biofilm. All wounds have some microbes, but of course that's natural considering what's on our skin. Biofilm treatments may be aligned across different chronic wound types, and a simple wound swab does not detect a biofilm. We need a biopsy and we need molecular diagnostics. and we don't have any molecular diagnostics on the coast that I know of, and so often a wound infection is just by assessment most often. But if you wanted to see what's in a biofilm, you cannot possibly do that with a swab. Biofilm-based wound care is the way of treating all wounds, particularly chronic wounds, and it, in a nutshell, is you debride the wound, then you apply a topical antimicrobial dressing, and hopefully you get a window. So if you use serial debridement, topical antimicrobial dressing after every time. So every time I debride a wound, a topical antimicrobial goes on, and that continues until we see some really good healing, movement in healing. So think biofilm. If you see anything chronic, think biofilm. Now, dressing selection. As you can see by this gentleman, choosing the oil in the supermarkets is quite difficult because there's so many choices. This is exactly the same in the wound world. There are thousands of dressing products. So let's talk about what we use after listening to those previous slides. As you can see, there's different dressings. You've got medicated dressings, you've got negative pressure, you've got bioactive dressings, you've got so many different dressings to consider. Now, the products that I'm going to talk to you about are, before I get to that slide, I'll talk about what the goal is in relation to dressing a wound. Priority number one is, has the patient got pain? Can we reduce the pain systemically? And can we reduce the pain using the right product? Or will we cause more pain by using certain products? You must rehydrate if the wound is dry. A cell cannot migrate over a desert, so it has to be moist. You have to absorb the exudate appropriately. We don't want a wet wound. We must remove the non-viable tissue. We must reduce the microbe load, and we must fill the dead space. That does not mean you pack a wound to death so it's so packed that the granulation can't develop. You may have to pack it lightly, or you pack with just the gel itself, depending on the wound itself. An ideal dressing maintains a moist environment. It's a little bit repetitive, my apologies. Protects surrounding skin at all costs. It's, as I said earlier, important as the edge and the surrounding skin, as important as the wound itself. Protected against any mechanical trauma. You must remove debris of any sort. It's amazing how many animal hairs I see in people's wounds. So we have to avoid, the patients obviously have their wounds open and their animals walk beside them, and we see a lot of animal hair. Again, fill the dead space. This is a little bit repetitive, this is slide, my apologies. You allow gaseous exchange if it's appropriate. Now, we don't put an occlusive dressing over anything that's infected, never. We need to have that gaseous exchange, and often our products are developed so there is some gaseous exchange. And it has to be comfortable, or our patients will take it off. It has to be easy to apply. It has to be a barrier to pathogens. Provide thermal insulation. A wound has to be the right temperature. You don't want it to be too cold, too hot. So leaving a wound exposed to have a look at it 2 hours later is not doing it any justice at all. It takes hours to get the temperature back to where it should be. It mustn't promote infection, of course. Does not shed fibers. A lot of our products that in the past have shed fibers, they're just a foreign body. That includes cotton wool or cotton balls. We don't use them ever again in life when we're cleaning our wounds. Does not cause sensitivity or allergic reaction. There's a lot of people that have reactions. They might have a product on for a few weeks, and all of a sudden they have a reaction to it. Be very mindful that people can be sensitive to them, even the most atraumatic type of dressings. It's adaptable to body parts, of course. Does not interfere with body function, of course, and it's most important, especially in private practice or anywhere really, it must be cost effective. So how do we know we've had success when we've put on a dressing? You can how many wounds have healed? Wound-free days. You might have a wound that's healed, venous leg ulcer. You've done brilliantly, the wound's done, you've had a compression on, the wound's healed. The patient takes the compression off, venous disease takes over, and again, it happens all over again. So how many wound-free days is important? Wound reducing in size is a really good sign that things are going well. We like to see about 20 to 40% reduction in 2 weeks in an ideal scenario. That's in the literature. We must see decreased pain. We're not going to have patients who are being able to, with pain, that are going to tolerate any sort of care if it's going to be painful. And this pain in itself limits the ability for our patients to actually adhere to evidence-based practice. So if we control our pain and we control the odour and the exudate, we will have decreased pain. So exudate, if you control exudate well, often your pain, you'll control inflammation, you control microbe load. Just controlling the exudate does wonders. Of course, eradication of infection goes without saying, and of course, increased quality of life. We want our patients to be on board with the care that we're providing, and they will do that if they have an improved quality of life. There's a few photos here that I'm going to show you. As you can see from this leg, this hasn't been cleaned for quite some time. We have one wound there, but around it we've got a massive hyperkeratosis. We've got probably many, many, many microbes under all of that. This leg has to be completely cleaned away if we can have any success whatsoever. Just dressing that wound there, putting on compression if it's a venous ulcer, is not going to cut it. The surrounding skin, especially of a lower leg wound, it has to be washed and maintained and moisturized, protected at all times. Hypergranulation is interesting. We see it a lot. I'm sure you do in your practice. There are many ways of treating it. It's usually due to its exuberant inflammation, often to do with bacterial load, but not necessarily spreading infection. How to deal with it? There are options. There's pressure, antimicrobial dressings. There's hypertonic solution dressings like Salt or Hypergel. And there's debridement, of course, conservative sharp debridement. Keeping in mind this is very vascular and bleeds a lot. But on the other hand, if all that doesn't cut it, there's always corticosteroids. This can be incredibly effective on hypergranulation. I've got a slide to show you that. This is it. This is the same patient, bilateral thighs, donor sites, as you can see, highly inflamed, very painful. There wasn't a high microbe load. We did have antimicrobial dressings on this to try and crush some of that microbe load, but it wasn't working. So I prescribed betamethasone dipropionate, and within 1 week, we had that. So corticosteroids, as I've said earlier, affect every stage of wound healing, but when they're used really appropriately for a strong corticosteroid or fairly potent and for a shortest period of time, as you're all aware, of course, this is the result you can get. And after we have a healed wound, and then we just simply moisturize with a very good quality emollient, and then we have a healed wound and a much happier patient. Now, hematomas. I spend a lot of time removing them. I quite enjoy it, actually. But we see, because of our patients on so many anticoagulants, and they just traumatize their legs quite easily, we have hematomas. Often when you debride a hematoma, the wound bed below is usually quite healthy. We might be able to remove some of it. If we can't remove all of it due to pain or whatever, we can often use certain products, which I'll talk about later, that will actually continue to debride the wound via autolysis. This goes for the acute wound on the left, and of course, although acute, the nasty lower leg on the right. Of course, there are some hematomas that are beyond our scope in the community, and then have to obviously go to the ED, especially if they're quite massive, like that first slide I showed you in the presentation. Here we have a pre-tibial wound, and that scalpel is pointing directly to bone. Of course, you can see the slough, the slightly inflamed wound edges are not too bad. The point I'm showing you is that bone obviously has to remain hydrated. This would be a low exudating wound, fairly low. So we have to remove all that non-viable tissue there, but at the same time protect the bone. We don't debride that, of course, and we have to hydrate the bone. So we've got to, we can do that with certain products. We can do all of that at once with certain products, which we're going to discuss. We've talked about the removal of hyperkeratosis on diabetic feet. We need obviously our podiatrists involved with offloading. It's so crucial. And of course, this wound is so much bigger than what we can see. But if you look closer into the center of that wound, you can actually see that there's probably a biofilm over all of that. It's because there's a bit of a slime happening, but the wound is, 3 times the size of what we're actually seeing. This is a very common problem on the bottom of this person's foot. Blisters, there's controversy about blisters, what should and we shouldn't do. Now, here's what we do now. When you have a blister, look at the tension it's creating. These are obviously, this one hand on the right, lower wound, and probably the one on the left, they're burns, I would imagine. I don't know these patients. Now, if you look at the hand on the left at the top, there's great pressure in that blister. We would just use a scalpel to make an incision. We would then just drain the fluid out of it, have a quick peek gently underneath that slit to see if the wound is nice and pink, particularly if it's a burn. And if it's nice and pink, I'll use that. Don't deroof the blister straight up, use it as the natural dressing. And after 2 or 3 or 4 days, when it dries out and shrivels up, you can peel it off and you'll have a nice wound bed. But initially, use it as the primary dressing and then control the exudate, etc. But if you look at the hand on the right, lower end, that is a very nasty burn of some sort. Again, not my patient. Now, you'll see the same thing applies without reducing the blisters by actually draining, because there's so much pressure on that hand from the blisters. But if you look closely at the fingers, they look quite white underneath. This is very concerning. So if you're seeing under the blister is really looking white and nasty, and the actual history of how this wound happened is crucial, particularly if it's a burn. First question coming out of your mouth has to be, was there any first aid? How did it happen? And so they're crucial questions to ask. So you're going to drain them, but this patient on the right, the hand on the right, at the lowest part of the slide, will have to go to probably the burns unit, I would say. Now the hand on the right, on the upper picture, that looks like a very superficial burn. It's had a bit of a blister. It's been drained and used as a natural dressing. You can see the pink skin. That'll just peel away. It'll have a superficial wound. It'll heal nicely. It looks like a young hand with some good blood supply. And of course, this blister on the toe here, lots of pressure, drain it. Hopefully there's not a lot of necrosis or something happening, because it's not a great color. It is concerning depending on the history of this patient, whether there's peripheral vascular disease, whether there's diabetic foot, and why has this blister happened on this toe? That's an important question. Why do these wounds happen is one of the most important questions you can ask. How did it happen? Was it spontaneous? Did it happen because of trauma? If a wound happens spontaneously, it's often a nasty circumstance. Speaking of nasty circumstances, in your practice, you may have seen wounds like this. This is nasty business. On the top left-hand side, you have something called calciphylaxis, where the vessels are, due to calcium, the vessels are just not, there's no blood supply. Now, this could be life-threatening. So if you see a wound like this, dry, necrotic, appear out of the blue, the patient is more often than not will be a renal patient on dialysis, but not always. This is serious business and they need immediate dermatology consultation. The giveaway will also be the incredible amount of pain they will have from this wound. I knew this patient. This patient also developed this on the abdomen, and then eventually decided to stop her dialysis. Of course, it was extraordinary. There was no way. You cannot debride this wound. It will make it worse. So just be mindful, necrosis and pain. Pain is the giveaway. Same thing on the right, the pyoderma gangrenosum. See the purple edge? Nasty wound. More often than not, these are extremely painful as well. How we would treat this wound would be to actually give oral steroids. Certainly dermatology consultation. Oral steroids would probably be prescribed, high doses. You can even use some topical steroids, but really the oral systemic corticosteroids are crucial, high doses. Pain, again, is the giveaway. You would not debride this wound either. Will make it worse. On the bottom pictures, you'll see vasculitis, again, very nasty, no debridement, usually very painful. These are awful wounds and we have to be able to identify them to treat them properly. Of course, dermatology must get involved with these sorts of wounds. Here we have a heel, dry, stable eschar. I don't know this patient, but assume this person had arterial disease, although it doesn't look like, because the foot doesn't look too bad, but pretend they did. Arterial disease, not great blood supply, but we had a beautiful, stable, non-boggy eschar. We are likely to leave it alone and not debride it, because you take that out, then you're got a hole remaining if they have no blood supply. Until it gets boggy or the edges start detaching and you get exudate, that's a whole nother ball game, and then you do probably have to have it debrided. Of course, this vascular assessment of patients is actually crucial in this regard. Skin tears, probably the most common wound around. We have to prevent skin tears from turning into the wound at the bottom. Just a little idea. Now, we want to do with the skin tear, of course, if we can save the flap, well and good. We clean what's underneath the wound bed and what's under the flap very gently with cotton buds. May I strongly recommend that when you're going to overlay flap back to where it first started, please don't use steri strips. Just place the flap, just gently flop it back. It's not going to reach the edge. That's okay. If it's viable, flop it back, no steri strips, then apply a dressing that's going to be non-adherent, and then when you've done the dressing, you leave it alone for about 5 days or so. Then, and also put on the dressing arrow of how it should be taken off in the direction of the flap. So very important not to pull the flap taut, it will not take. Next one. Oh yes, dermatitis. We see this an awful lot. Often it's due to high exudate. We see masses of this sort of problem. So again, as we talked about corticosteroids affecting every stage of wound healing, but there are circumstances, particularly on the lower legs, that I use corticosteroids. Often I'll go for a Risticort 0.02%, moving up to probably possibly a betamethasone dipropionate, depending on the level of inflammation. And so you're fairly strong and potent for a very short space of time, so about 5 to 7 days. But very quickly, these wounds, the legs that are inflamed, it does look, in this patient, it looks like they've had a reaction to the dressings, but often it's due to high exudate not being controlled well. So we get rid of the inflammation, that gets rid of the pain, then we stop the corticosteroids, and then we can manage the legs well. May I suggest that if you are using a corticosteroid, you know they dry the skin out, and a quality emollient, something like a QV lotion or QV intensivo over the top of the steroid is actually quite satisfactory. You'll stop the drying out. And once we get control, now we're going to use any sort of, we don't use soap on skin at all. So if you can advise your patients not to use soap at all, we just use the non-soap washes available in the pharmacies, sometimes in the supermarkets, because soap is going to rip your acid mantle off, and it is very destructive to skin, particularly aged skin, or anyone's skin really. So here we have a gentleman who decided to play golf in his new golf shoes. As you can see, this second toe is looking larger. It's a bit like a sausage. This is a giveaway. You see a toe looking like a sausage, it doesn't matter what size of the wound, and you know you've got a problem, and it's likely to be osteomyelitis. This toe wasn't very red. As you can see in the middle of that wound, there's a tiny little hole that actually probed through to bone. He had a significant osteomyelitis and his toe was amputated. You can tell by looking at the foot and the presenting metatarsal heads and the pressure there that he has diabetes, but his new golf shoes has resulted in an amputation. Even though, you know, it looks like you can just remove a non-viable tissue, you'll be fine, but no, just look closely, just get the history of how this happens. Now, here's an acute wound, yay. We've got resulting from a bypass, where the vessels were taken. Yes, all that non-viable tissue has to go. We have to be very mindful of these wounds that have been created by the surgeons and they're broken down. It's a common problem. Debriding this with using wound products is advisable, and I know that because when I get wounds like this, considering the history of the wound, how it happened and who was doing the surgery, I rang this particular vascular surgeon up. I said, I just want to confirm that where the anastomosis is. And he said, I don't want any sharp tools near it because the anastomosis is actually just below the skin. So be very mindful. There are times where you can't use those sharp tools, those curettes and scalpels, and we just have to rely on our products, which we're going to talk about in one moment. Antiseptics. As you know, the topical agents prevent growth and reproduction, but they don't kill the bugs. Disinfectants kill the bugs, but they're harmful to humans. And antibiotics slow the growth or kill microbes. So that's that in a nutshell. And we're going to talk about those sorts of things in relation to products in a moment. Now, the products I'm going to talk about are what we use in our service. That I have no conflict of interest. I have no association with any of the companies. Now, let's look at these. Hope I'm going all right for time. Saline, ordinary. Am I going all right for time?
Yes, all good.
Good, good. So we look at saline. We use it all the time, everywhere. It doesn't do much for the wound, it just cleans it a bit. It's not very great at all, but it's better than nothing. So we're going to continue to use it because it's cheap and it does clean the wound somewhat, but it doesn't really do much about killing bugs or anything like that. Betadine Solution, most amazing product really. It's been around for I think 170 years. There's no resistance to it. Powerful killer of microbes, of all sorts of microbes, and can really disrupt some biofilm. However, once upon a time, back in the dark ages of the 70s when I started nursing, we used to use pack wounds with it all the time. But we now know by looking at the cells more closely that this can destroy cell growth. So how do we use it in our service now? And we still do use it. If you have a really grotty, revolting wound and you just want to knock off some bugs, you can actually do a betadine soak with some gauze. You sit it on there for 10 to 15 minutes and then you remove it and then you clean the wound, the betadine off the wound, and then you dress it. So it is very useful still, but if it's used properly. It's not going to be a primary dressing. It's just there to just knock off as many bugs as you can before you do the primary dressing and secondary dressing. Most important. Down on the lower level for a moment, we've got acetic acid, a very useful product for killing Pseudomonas and other bugs. 3% is what we get from our pharmacy at the Gosford Hospital. You can use less of a percentage with some success. Again, like you would use the betadine, you would actually soak the wounds, and then you remove the soak, and then you can use your primary dressings that you've chosen. Be mindful though, using betadine or acetic acid on wounds, they can cause pain. So I can't use them on patients that have pain. I just don't even go there because it's too much. Now the Chlorhexidine Microshield down on the bottom, second from the bottom. Useful if you've got a really grotty skin, legs, whatever. Great to use it now and then. You don't want to clean your leg, you've got to watch the commensals. So don't use it all the time. When you've used it a couple of times, then probably wash the skin with something like a non-soap wash again. So try not to use these things all the time. If we look at hydrogen peroxide, we hardly use that anymore. Yes, it bubbles up and it looks great and it kills the wound, it kills some bugs and it cleans the wounds. But we don't use it because it can be dangerous. If there's any sign of any sort, there's a risk of emboli, and we try not to use it at all in the wound world these days. Two excellent products are Prontosan and Microdicin. They have different components, as you can see. Now they both are going to affect and detach the biofilm. That's what you want. They are great cleansers. You can actually do a Microdicin or a Prontosan soak. This will start detaching the biofilm and the non-viable tissue from those wound beds. You can also then move towards the gels that they produce, which will continue that process. So it kills bugs, hydrates the wound, detaches the biofilm, cleans the wound. So these actually be very useful products in your practices. Now, you've probably heard there's lots of silver products. They can all be quite beneficial, but none of these products here will debride the wound virotolysis. So they're probably very useful after you've actually applied a topical local anesthetic, you've debrided the wound beautifully, and you want an antimicrobial to go on it after that. These are very excellent products for that. So, but don't expect them to clean the wound, but they will control the microbe load. Aquacel AG Extra, that's very absorbent. You've got Actazorb, which is silver, and charcoal, which will actually help. It will take the exudate and the bugs into the dressing and kill the bugs, and also as the charcoal will prevent odor. The Atramin AG is just like a mesh. It's used the same way as you'd use the Aquacel on a lower exudating wound. So Aquacel AG on the left there is a higher exudating wound product. Actazorb is probably moderate to high. Atramin AG is just a mesh on a low exudating wound after debridement. Acticate 3 is a powerful killer of microbes, and of course is activated by sterile water, not tap water and not saline. It has to be activated. So if I've got a highly exudating wound and I've debrided it, I don't need to activate it with water. I can just place the mesh on the top, then the exudate will keep it moist. But if it's a drier wound, you will have to hydrate the actual product to actually activate the silver. Very, very good product, but the wound must be debrided and cleaned first. If we go back to that slide on biofilm-based wound care, that's what we're talking about. So these are the products you're going to be using that I'm presenting now. After you've debrided the wound and you've cleaned it, these will keep those biofilms at bay, hopefully. Now, Mepilex AG, anything with the foams are very atraumatic, very, very gentle for low to moderate exudating wounds, usually after debridement. Again, they will not debride the wound, but great after debridement. I usually use them on a lower exudating wound. Also, the stickiness is a silicone, therefore it's atraumatic, great on surrounding skin. Patients find it very, very comfortable. So silver is a powerful antimicrobial, and if it's used correctly, it can be most beneficial after you've actually debrided the wound, but they won't debride. Okay, Inodine, I use it a lot. Low exudating wounds. It is povidone iodine like betadine, however, it is slow release. So if you've got a low exudating wound and you've debrided, or even if you want to keep the bugs at bay, use that. It's actually an excellent product, and it will keep the bugs at bay. Now, iodosorb. I know you're not meant to have faves, but it's one of my faves, and it is a cadexamere iodine. It's an iodine in a starch base. It's not the same as povidone iron. It's slow release. The iodosorb is used on lower exudating wounds, the paste, and the powder on much higher exudating wounds, and it's very absorbent. This will detach the biofilm very successfully. It will kill the bugs brilliantly, clean that wound beautifully. It's an excellent product, particularly on the diabetic foot. So always consider it if you've got a small wound on a foot. Beautiful product, particularly that on the diabetic foot. The paste is very useful. Excellent product. Sore back, you might like this product, one, because it's effective. It's our first line antimicrobial, usually in our health service. It's a mesh. If you can see, there's all different types of variations. This has this, I won't attempt to say this word where it says DACC. We just say DACC because no one can pronounce it. But what it is, a chemical within the dressing. So when the bugs attach to it, they are killed within the dressing, but they do not expel their contents. Thus, their exotoxins aren't expelled. So, and then when the dressing's taken away, the bugs go with it. It's actually a very successful, comfortable product and inexpensive. We have a version now that actually has the same mesh, but it also has a gel on the left there. It has the hydrogel impermeated into it. So for those really low exudating wounds, to prevent sticking and making it really quite comfortable. But it's quite a good, so I'd look into that if I were you. It's a useful product. Solicite, you've heard of Solicite. It's basically water, but it does debride and it is comfortable. It does not kill bugs. Wound Aid on the right has got tea tree oil in it, great for killing bugs. It's quite a useful gel. Hydrate the wound, and it will clean the wound nicely as well. It will debride the wound as well, and will actually affect some of the biofilm. Honey, powerful. Honey is a powerful killer of bugs. Great at cleaning wounds, wonderful. But be mindful, if the wound is wet, it will macerate the wound and also can be painful, unfortunately. So be mindful of that. Now, there's a product I've added only today, actually, which I forgot earlier. It's called Flammable Hydro or Flammable Fort. This is a gel that's got enzymes in it, and it's also got an alginate in it for absorption. And it is actually a very useful product, and it's not expensive. So the hydro is for those low exudating wounds, and the fort is for those moderate to high exudating wounds. It is a great killer it kills biofilm. It cleans the wounds very nicely, and it's actually a very effective product, I must admit. So that might be very, very useful and versatile in your practices. So, have I got time for a case study? This is almost done. This patient was referred to me because, and she's a female, 54. You can see the history there: hypertension, thrombophlebitis, anxiety, smoker, medications. There's not too many of them. She just happened to fall on the dirt, minor graze, left pre-tibial area, swelling, good pedal pulses, minimal pain. She's about, if I remember rightly, she's 54. She's had numerous courses of antibiotics over a 9-week period, which were not effective at all. It was not healing this wound, and I'll show you why in a moment. And of course, she went to ED and had 1 dose of Kefazole and IVI and was discharged on Keflix. As you can see, on the 28th of January this year, this is how the wound presented. 9 weeks, antibiotics, swollen, painful, red, not healing. With that mark I've put on there, it shows you the amount of undermining underneath. There is no way that this wound will heal without the removal of that eschar. So when we first saw the wound and her anxiety, etc., we actually sent her to the ED. They unfortunately did not. They actually discharged her, which was most disappointing. Never mind. So the GP removed the eschar, and then, and you can see on the 1st of February, this is what it looked like. Actually, to be very honest with you, this is how I sent her into hospital. That was the 1st of February. The GP and I decided this is a much, much deeper wound. It needs surgical debridement. We really needed to clean it properly, and it had to be done and dusted, put negative pressure on it, all would be well. That's when they sent her home. We were, and again, most disappointed. So since they sent her home, we decided to do bit by bit. We decided to clean the wound a little. So as you can see, we measured the undermining. We placed our EMLA, the topical arsenic, in, and we left it for more than an hour. The patient actually applied it herself. We slowly but surely debrided the wound. We got it back to a stage where we could actually change. And what we did, once we debrided it, we used a Prontosan Gel. I mentioned it before, one of those gels that continues to debride, continues to hydrate, continues to kill the bug, the biofilm. So this wound is filled with biofilm, non-viable tissue, undermining, pain, infection, nasty. So removing the non-viable tissue first, slowly but surely debriding bit by bit, using after we've debrided a product that will continue to autolytically debride. I saw her weekly. As you can see, the wound bed changing, the undermining resolved. It's getting cleaner and cleaner by the 1st of March. The swelling went down because she had a little bit of compression on. We did do some vascular studies on her. She didn't have a lot of pain, thank goodness. And actually, I saw her only this week. The wound is now half the size of the one that was taken on the 15th of March. We went from just using normal dressings like gel and debridement. Then to finish it off, we've used a negative pressure wound management to continue to healing process and to get her heal more quickly because of her anxiety. So all in all, it can be done. Just got to get rid of that non-viable tissue. You've got to consider autolytic debridement, killer of the biofilm, removal of non-viable tissue, good antimicrobial dressings, systemic antibiotics if required, and the right products. So you need to know your products. So take-home message is know and adhere to the standards. Think holistically. Everything affects wound healing. You need a multi-D team. There's no doubt about it if you're going to get good results. Know your dressings. If in doubt, consider pain, exudate, non-viable tissue, microorganism burden, and wound specialist input. These are those documents I was talking about. If you go to Wounds International, there's so many of them. The one on the left here, the 2022, has just come out. They're excellent documents, and it really will get your knowledge up in relation to evidence-based, current evidence-based practice. And there's all the references there. And are there any questions? Hope I didn't talk too fast.
Wow, Anne, that was amazing, so informative, and you've done so well covering such a huge area. I know each little component probably can be a whole topic in itself, but yes, I'm blown away by the biofilms and 250 organisms in a little wound. But
I know,
just a few questions. One would be about the frequency of dressing changes.
Yes, and often I advise my nurses, so think exudate. In that regard, if you've got, you don't know how often do it, think exudate. If it's high exudate, obviously more often, depending on the products that you're using. If you're using a combine on a wet wound, you're going to have to change it all the time. But if you're using other products that are much more absorbent, you have to change it less. It also depends on how infected they are, how much pain there is. But really, as a guide, think exudate. These products, mostly primary dressing, are designed to last more than a day. Those silver products can last up to a week, for example. Iodosorb can last up to 3 to 4 days. Those Prontosan gels and Macrodicin gels up to 3 or 4 days. So to change them, it's okay to leave the dressings alone because they're doing their job, but exudate is the determining factor.
Great. And another question you mentioned about changing dressings can be really painful. What do you recommend for pain relief? I know in the past we've had to even use like the green whistle or the Penthrox when changing dressings. It's been so. What do you use usually?
We don't actually have the Penthrox in our clinic, unfortunately. That host will come in the near future. But what I find, if you've got something that's adherent, if you have something like a Prontosan solution, for example, you can actually, a saline you can use and soak off the dressing, or there's the shower, you get the patient to remove it in the shower themselves, or get them to remove the dressing in the clinic themselves. But if you use something like Prontosan or Microdicin Solution, it's got, the Prontosan particularly has a surfactant in it, so it detaches the dressing. So that can be very useful to have Prontosan Solution in your practices for those wounds that are painful. It is really, and really it's the dressing that's going to be applied has to be able to come off. So if you know that that's going to stick, you don't use it. Find something you know is going to be atraumatic. I hope that helps.
Yeah, that's great. And another question would be, I suppose, referral pathways, like if we have a wound, like the extensive ulcers that you showed, and you mentioned, oh, this patient needs dermatology referral. As you're well aware, we are very lacking dermatologists on the Central Coast.
It's terrible, yeah.
So what would you suggest regarding referral pathways for GPs and nurses?
Obviously, if you have doubts about the vascular status, it's, I mean, we do ABPIs in our service. You probably do the same in your practices, but that's a guide. If we want more definitive tests, you know, we need probably some really good vascular studies. Obviously dermatology, that's a really difficult problem on the Central Coast with the lack of dermatologists. The diagnosis of the wound, referral to expertise. Of course, GPs can refer to our specialist wound centre or community nursing if you've got a problem wound, just to keep you, but we will always keep the GPs informed. But if the GPs have been trying to do this for a while, it's just not, it needs some expertise. Of course, referral is appropriate, and we have a system for referral, a proper referral form. You have direct referral. Then I would often hand the patient back to the GP, or sometimes, depending on the patient's wound and how the severity of it, whether they actually stay in wound in the community nursing. The reason why sometimes I have patients stay in community nursing is because 84% of a community nursing work is wound care, so they do it a lot, and also they've got access to all the products, etc. But quite often I'll also refer back to the GP. But there's a specialist wound centre, you've got community nursing. There are the private nursing services as well for some people, but their wound experience is not the same. I don't mean that with disrespectfully. Is that the sort of thing you want, that you're talking about?
Yeah. And I suppose if we need to escalate it to the next step without necessarily sending them to emergency. So obviously you mentioned with your patient's wound and she was sent to emergency and it wasn't necessarily managed the way you would have liked and they were discharged. So, you know, rather than send the patient to emergency, where can we go? And
there's also telehealth. I do a lot of telehealth with some of the aged care facilities. I don't do it much with the GPs because we just don't, but there's that facility as well. I have so emails with photography. I can often consult, myself and my other colleagues, of course, can actually consult online and give you ideas where you need to go. That's doable as well. Actually, that last patient, that case study, that original photo was a phone photo sent to me to my mobile, and that's how it started. So we get a few of those. So as long as we can, a conversation, a call, a picture, anything like that, we can actually put you in the right direction. And I do the same with you guys. I ring you up and get some advice from you guys, so we collaborate and we'll get a really good result. Yeah.
That's great. And just one last question. You mentioned, you know, about obviously swabs aren't very helpful, but biopsies can be useful. So is that something that we can be doing in general practice?
Yes, biopsies, but you won't get any molecular diagnostics here on the coast. So biopsies, obviously, for malignancies, if in doubt, it looks a bit odd, please get a biopsy, do a biopsy. I don't do the biopsies in the specialist wound centre. Basically, it's a Medicare issue. And that's why I send them back to you guys, the GPs. And just wound swabs is exactly because if I do all the ordering, it becomes very expensive for the patient. It's just a Medicare issue. But yes, biopsies, if you have any doubts that there might be something suspicious, or a wound, a chronic wound that hasn't healed for a long time, can quite often turn into malignancy. So what else? Testing for a biofilm, we have to just rely on this assessment because we're not going to get, you've got to pay a fortune, send it down to Sydney and get a molecular diagnostics done. We just don't have that capacity, but we can pretty much guess they've got biofilm by just looking at them really and dealing with them accordingly. Yeah, does that make sense? Yeah.
Great, thank you. And Melissa, can you see any more questions there at all? I can't. unless
Chair?
you can see.
I think it's been extremely well covered, and no, there's no more there. Thank you, Georgia.
No
Yeah.
questions.
Great. Great.
They're probably all
Because
gone.
you've done such a fabulous job, you've answered them all for us.
Thanks, that's good. There's a lot in that presentation. As you said, there's in an hour, but hopefully it wasn't too rushed.
It was excellent, and we can always go back and refer to it afterwards anyway. So it was fabulous. Thank you, Anne.
Cool, excellent, thank you. So
Okay,
what happens now?
I wanted to thank you both for being here tonight, and really appreciate both of your time, and that was really informative and really interesting, and I'm sure everyone got a lot out of it. There will be a recording, as Georgia has just told us as well, in the Education Library, along with a copy of the presentation. And just a reminder that the survey is going to pop up once I end the webinar, so if you could please fill that out, we really value feedback. Thank you everyone for being with us here tonight. Have a lovely, lovely evening. Thank you, Georgia, and thank you, Anne, as well. And see you all soon. Yeah.
All right. Bye-bye.
Take care, everyone. Bye.
Bye-bye. Bye-bye.
Bye. Thank you.
Trying to get out. Hmm.